Good morning, good evening to all parts of the world that you all have logged in from. Firstly, I'd like to thank CyberSight for this opportunity to present. It's just under a year that I presented last on ROP. The last time I'd spoken a little bit about the newer technologies, the biomarkers that we've been using in tiers. But this time, I've been requested to speak on scaling of a program, of setting up of a something like what we do here in India. And I thought I'd share that experience with you, our 18-year plus experience of running a telemedicine program here in India. I thought I'll speak briefly about how to set this up, the challenges that we have faced, and so that other programs across the world don't have to reinvent the wheel. And of course, we've reached a point where we can collaborate with each other and take this program to different parts of the world. I have no financial or relevant disclosures. They are up here. I'm the unpaid PI for some of the devices and the algorithms that I'll be speaking about. So firstly, how big is this ROP problem? 10 years down the line, India still leads the number of countries with the number of premature births. What's really important here to understand is while survival has improved, ROP practices have unfortunately not caught up. And while China was number 2 10 odd years ago, now that list has changed a bit. But what remains is a very large number of preterm babies who are surviving today because of better neonatal care. As you can see, there are several reasons why this may happen. Better survival is definitely one of them. But somehow we've not caught up as ophthalmologists or ROP specialists in taking care of the ROP problem while these babies continue to survive. Our story really began in 2007 when I joined the institute. And in a very short span of time, we saw a lot of stage 5 babies unscreened and coming from the rural areas. While we were operating on them with some amount of anatomical and functional success, well, it really wasn't quite the way we wanted to scale up the program. And really, indirect ophthalmoscopy done by the limited ROP specialists was not going to be the answer. And I think that's what gave rise to the birth of the Karnataka Internet Assisted Diagnosis of ROP, which you've probably heard of as the KIDROP program. So how do you really set up an ROP program? Well, these are learnings from our own Indian program. And this is the document that's available online. And I've really taken lessons from there and, of course, our own journey. So the first thing you need to do is how to map up the need assessment. So let's look at how India was in 2007. There were a lot of babies. If you extrapolated that to the incidence of treatable ROP, we would find that every 2 hours, somewhere in India, even back then, 3 babies required treatment. So then our idea was, can we replace the so-called ROP specialists by non-physicians, technicians with technology? And at that time, the only available camera, the only portable available camera was the RedCam shuttle. So that's what we used. And we would put it into the SUV and then we would take it to the NICUs. The next step was assessing the at-risk population. So firstly, your risk population are the babies and therefore their families and their parents. And therefore understanding the rural, the semi-urban or the urban demographics that they came from and how you can improve that is very essential to making it successful. The second one is, of course, working with the neonatologists. If there were centers like we had, with a very high incidence of severe ROP, in some cases when we began, it had an 80% incidence of ROP, with more than half of those in zone 1 ROP. So then how do you reduce that incidence by improving the neonatal care? And that's what we were able to do by working with neonatology groups. Thirdly, of course, are the stakeholders of the families of these babies who come from the rural areas. And we were trying to see what are the reasons why they may enroll, but they may fail to follow up. Some of these, and this is there in this publication, some of them are genuine reasons of distance and babies falling sick, but many others could be modified if only we increased their awareness and told them how important the disease was and not to miss follow-up. The third step, of course, would be to assess what are your eye care providers that you have? What are the trained resources that you have? Now, understanding the limitation of what we were dealing with we felt that the best way to make this a successful program was to work with the government. And in India, we call it a public-private partnership. And that's what we did. And what we were able to achieve there was to provide completely free screening and free treatment to babies born in public or government hospitals and have a cross-subsidy model by charging patients from the private hospitals. And this we've been doing since 2008. We, of course, had scores of ophthalmologists, nurses, technicians, optometrists, ophthalmic assistants, and what have you, coming down here and getting trained. We then validated what we saw as non-physician or anyone who could be trained to take an image. But what we did differently was also to train them to grade that image live. And we used a score that we invented called the Score for Training and Accrediting Technicians, what we call the STAT score. And with that, we were able to teach these imagers to take an image and to decide whether these babies will need follow-up, will possibly need treatment, or completely normal if they were able to image the aura. And based on the skill of these imagers, we were able to divide them into levels of technicians, level 1 being early career, level 3 being the experts. And as you can see in these images, their ability to, for example, image the aura serrata in level 3 is just improved. And to be able to make subtler diagnosis like stage 2 with plus disease, which is harder to make a call on requiring treatment than a very more obvious aggressive ROP, which back then was called aggressive posterior ROP. And what we found repeatedly in our studies was that these technicians absolutely did not miss any disease that required treatment. We also had, and if you recognize this is Apple's first iPhone, the ability to look at these images on the go. And I think that was important because, as you know, once you make a diagnosis of requiring treatment, it has to be done within 48 hours for best outcome. It created quite a ripple back then because it was the first medical grade app to be on the Apple or iOS store. The next one is, of course, once you've done all of this, to actually provide the screening and treatment. So here's a day in the life of the KIDROP program as of now, where we use more portable cameras, particularly the Forus Neo camera. So we set it up in an ICU, and this is a government setup. The team sets it up, takes note of all the data of all the babies that are scheduled for screening on that day. There are, of course, inpatients who are being screened while they're still admitted. And then there are many who would come back for follow-up, of course, if you've been able to make sure that they're reminded to come at the correct time. Inside the NICU, of course, this screening is going on, male and female nurses, and as I told you, any cadre has been trained to do this. Most importantly, using these images to counsel both the parents and the decision makers of the family are critical in making them understand the importance of the disease and why they need to come back for follow-up. Where we started with 3 NICUs, we are now about 190 in our state. That's a busy slide, but we have about 5 zones, 5 cameras, 5 vehicles, 5 trained teams that move on between few districts every day, working 5 to 6 days a week, depending on the workload. On an average, we do between 3,500 to 4,000 screening sessions every month, and that's the cumulative total as of the end of last month. Close to 400,000 babies imaging sessions, that is, unique babies, close to 120,000 preterm babies, over 5,500 babies being treated. Well, much before the COVID pandemic, we were able to luckily develop an online training portal as well, where initially the trainees would come spend a shorter period of time with us and then go back to fine-tune their skills in their resident SNCUs. We are very fortunate that with the help of the government, we were able to continue the program even through the lockdowns in the COVID period, right from 2020 to the end of 2021, when we had all those pandemic lockdowns. And, we were able to even treat babies when some of the NICUs had actually shut down. Recurrently, what we found from our data, the multicentric data, for example, in this publication about over 20,000 sessions, we found that the incidence of ROP in rural areas in India was absolutely comparable to any urban setup anywhere else in level 3 NICUs in the country. The treatment requiring ROP was also roughly around the national average. And this, mind you, was rural data. And all this time, it was believed that ROP was perhaps a disease of the affluent, with only 600, 700-gram babies who survive in corporate hospitals in cities developing the disease. But our rural multicentric data proved that the rural babies were equally, if not more, at risk. What this program started showing was that these trained technicians obviated the need of the ROP specialist in the rural areas. And as you can see highlighted below, we suddenly stopped seeing unscreened stage 5, where we began with 18 babies in just 3 months. But where we failed to scale up this program was the cost of the RedCam shuttle, which even at that time was close to $100,000, probably a little more now, at least sold in India. At some point of time, we had to see whether this was financially viable, because we were, at the end of the day, doing free screening and treatment for public hospitals and charging only the private patients. So we had some of the top business schools of the country come and study our model, and they found that we are not only going to be viable, but also scalable if we did it in that proportion. Some of the external validations that we got were from ministries, both our Ministry of External Affairs in 2009, then being written about by the Harvard Business Review as an example for reverse innovation, which basically meant that in higher income countries, models like these could be used, even though there are fewer babies, because it's more cost effective. And of course, this was a big UNDP report, which reported several such programs, not just ROP, but many others in maternal and child health care in Southeast Asia and in lower and middle income countries, and called KIDROP a good practice for such a regional setting. This is one of the most critical reports that we received from the University of Western Australia, backed by the Australian government university, which validated our program based on the CDC guidelines. And what they found was the ability to image ROP could actually remove not only the risk of medical legal liability, but also provide better care. Let's stop quickly now for another poll question. So if you are part of an ROP screen program, this describes it the best. You are using only indirect ophthalmoscopy, you're using only imaging, or you're using mostly indirect ophthalmoscopy with imaging in a few cases, which of course presupposes that you already have a camera. And it doesn't require to be a RedCam or a Neo. It could be anything. It could be a mobile-based 20D adapter camera. So anything where you would photo document. So that's the question for you. And let's wait on for the results. Great. And this is wonderful, because since the last time we polled, where most of the participants were using only indirect ophthalmoscopy, today we find that the majority, the bigger proportion, is actually using imaging as well as indirect, which is a wonderful change from last year's webinar. Great, let's continue. The next one, of course, is advocacy or health communication. And we were fortunate that about 12 years ago, we started the National Task Force under the leadership of Government of India. And at that time, supported by the Queen's Diamond Jubilee Trust, which then after a period of 3 years, went back to doing other projects, and where India took on the lead and then went on to make several very important documents and guidelines. The first one being the Rashtriya Bal Swasthya Karyakram, or the RBSK program, which spoke of many conditions that affect babies, especially our preterms, and made ROP a very special vertical within that program. And the operational guidelines that I showed you the screenshot of right in the beginning was an aftermath of that. The next thing we were able to do in India is to galvanize all the ROP specialists, established over almost a decade ago now. We started off with 6 mentors, and now we are close to 300 members. And now this is not an academic group. This is a group of ROP specialists who are actually practicing screening and or treatment in several parts of the country. And all of them are currently ophthalmologists. This publication in the Lancet, the credit really goes to Sam and Dr. Patole from Australia, where they compared the success of a very hugely successful program, public health program in India, which is the polio eradication program, and compared it with the ROP program. And we said, what are the lessons we can learn from them? And how can we inculcate that into the ROP program to make it better? And as you can see here, mobilizing political support, having an ambassador, strategic policy development at both the regional and the national level, partnership and coordination of multiple organizations, be it NGOs or philanthropists, making metrics in the operationalizing of these programs so that we can measure how successful the outcomes are, and of course, independent monitoring. And the ones you see on the right, which is written in the red font, is where that's work yet to be done. And that's lessons we've learned from polio. So how do we then scale up a program, assuming you started in and around your epicenter? Well, the first thing we had to do was to look for an alternative, affordable technology. And we are very grateful to Forus Health, that took this challenge up. And they were at that time making very successful devices in adult imaging. And then they created what probably many of you use across the world as the Neo camera. As you can see, quite obviously, the size difference, its portability, and also the resolution and its ability to be taken around in smaller vehicles, including three-wheelers and trains and buses, and even two-wheelers, suddenly reduced the operational expenses of our program, and not just ours, probably elsewhere in the world. These were the initial prototypes, which now, of course, you've seen them all improve. They have a HD version as well. Basically, this is as portable as it can get, sits in that small briefcase. And this is the publication where we compared the Neo camera to the RedCam. And Forus, along with IIT Madras, went on to win the BIRAC Innovation of the Year that year for this contribution. Again, this was made under the Make in India scheme, where several technological advances were supported then and even now by Government of India. They do have now what they call the Forus HD, the Neo HD camera, which has the angiography, which I think is such an important tool, especially in the era of anti-VEGF treatments. Let's stop here again for another quick poll question. Read this in first person, of course. In my ROP program, there is an in-house ROP specialist, an outsourced ROP specialist, screened by an ROP imaging team periodically, don't have an ROP specialist. Now, of course, you might be the ROP specialist, in which case you need to answer that as someone who's going into the NICU as either part of your hospital, in which case you will be in-house, or you are an independent practitioner being called, let's say, to a medical college hospital or a standalone NICU where you'd be the outsourced ROP specialist. So read it that way. I just want to get an idea of how the demographics are playing out in different parts of the world. And the results are out. It's almost equally matched with don't have an ROP specialist, which is actually the highest. Just closely followed by an in-house ROP specialist. Screened by an ophthalmologist, an ROP imaging team is at number 3, which is interesting. And an outsourced ROP specialist is the least. Interesting. So that basically means that almost half of the audience listening in don't have ROP specialists at all, which then, of course, is such a great room for improvement and progress, and wonderful. Okay, so while our data started coming in regionally, we were making some impact on policy. For example, because we were able to validate that trained technicians, non-doctors, were able to take these images and grade them so effectively, so accurately. I think India, and this is the operational guidelines I was referring to, which came after the RBSK guidelines, probably a year after, which showed, and I think India is the first country to allow imaging-based ROP screening, and that too by a non-physician. And I believe there are several other countries, especially in our neighborhood, that are following suit. What's important here is to understand that an image can really capture anything. It just doesn't have to be ROP. And that smaller inset on the right is our other diagnoses that we were picking up while screening for ROP. And the paper on the left, the one with the larger inset, is the one where we can use imaging to actually do universal screening. And I think that's interesting because several countries, even in our neighborhood, are advocating universal screening, but don't really have the operational know-how on how to do that. And they feel that imaging is a good idea, but perhaps not scalable or perhaps not as effective. As you can see from this publication, which we of course extrapolated to to Indian data, close to 200,000 babies every year may be picked up with having some treatable condition. Either it's medically treatable or surgically treatable. And as you can see in the inset, we were also picking up lesions like retinoblastoma quite serendipitously while screening for ROP. So that's some food for thought for those who are into policy for universal screening. Now, since I understand that the audience here is so many countries outside India, I'm only going to take the generic understanding of what we've had as a problem with the medical legal problem in India. This is not new to several countries, and perhaps has not become a big problem in many others, but it is a problem that we have to address. And perhaps imaging would be one of those that can sort it out, as you saw from that CDC guideline report. This one of the publications we had a few years ago where we said, what are the lessons we can learn from some of these judgments? And I'm going to quickly go over them. Again, let's look at it generically because there is audience outside India. But what the courts look at are what is the guidelines that your country needs to follow. And if your country doesn't have, for example, a national ROP screening guideline, then they simply look at your neighbors or they look to the West and they say, well, if there is a screening guideline somewhere, you should have been following it. And that's exactly what happened to that big case, which I just showed, the Supreme Court hearing. That was a very large payout, probably one of the largest in the history of medical negligence in the country. And that really in 2015 sort of created a wake up for the ROP program in India and elsewhere as well. The next thing we all must remember is documentation. We always talk about good documentation preventing medical legal cases. For example, a simple thing of mentioning the exact date, time, and venue on when the next ROP screening needs to be done is imperative in the way we document follow-up. This was an important case here in India, but I think it's important to understand that as a neonatologist, you would be liable for babies under you during admission or after discharge if they are coming back to you for, let's say, immunization or some other neonatal care practice. If you've not screened them during their admission, you must highlight the need for screening them just after. The only time where you may not be negligent is if you have absolutely documented in writing and of course explained it to them that they need to come and for some reason they did not. That's the only time perhaps you can be saved of medical legal negligence if it's documented well. And again, these are lessons from India, but perhaps the rules apply elsewhere. This is something that we have been using in India now to a good amount of success, and I'd recommend it to countries which are still developing their programs. What we call here is a 1, 2, 3, 4 rule, and it goes well for us because we have the 2 and the 3 as part of our screening guidelines. So that means the first screening for 2 kgs for 34 weeks or under, and between the 3rd and 4th week of life. So that's the 3 and 4, again in the 1, 2, 3, 4. So this is a very simple mnemonic, which a lot of neonatologists remember, and we also print it out and post it in and around the neonatal intensive care unit. The next one is to create a very hard stop on when that first screening needs to be done. For example, we have slogans in the local language where we emphasize that the first 30 days are critical. So to have the first screening before the baby turns 1 month of life or 30 days of life, and we have it in our local languages, and we've propagated that as something which is easy to remember even for parents. Also, how you document this in a baby who's admitted in the NICU. So in our program, we leave behind one of these sheets back in the NICU. The other one our team brings back. And this is a sample of the card that we give to the parent which is usually kept in the inpatient file, which they take home with them when they're discharged. And it's really important to have a good equation with the nurses so that they hand this over when they're discharged. Now, copies of this card are available on the KIDROP.org website. You're absolutely free to download it and use it and change it to your language or your setting. We have no IP on any of this material. Last webinar, I spoke more about how we've been using tear biomarkers in the tears of these babies. We've had some, good success. We have a few publications on that. So I'm not talking about that this time. This time I'm going to a little bit focus on artificial intelligence, which I had briefly touched upon in the previous webinar. So this is where we were last year, where we were creating standalone algorithms that used deep learning, machine learning tools to create algorithms that were either detecting plus disease or vascular severity scores, or being able to detect some amount of disease in the periphery. And the success rates were modest to good. We were also seeing how we could use poor quality images that sometimes come out of any camera and extract information by both processing, both in the 2-dimension or the 3-dimension. And then, of course, the ability of an algorithm to detect a stage 2 versus a stage 3. So this was all some years back. This was around the time my previous webinar was, where we were using algorithms to see how we can train technicians under different settings. As you can, some of you might recognize some of the authors. They are from different parts of India, and they all have successful ROP programs. And we wanted to see how AI can be used to train the people within their ecosystem. I'm going to speak a little briefly now upon the prospective work that we've been doing with Remedio in the new algorithm. So, well, firstly, we wanted to develop an algorithm that was able to detect the disease. We started off with a decent number of images, close to about 225,000 images, and we decided that we would have a filtering mechanism where we would look at temporal images to decide whether there was the presence of disease or not. It seemed like an easier way to do it. Of course, there were times when nasal images also had to be used for the disease, but you'd probably understand why we use temporal images. So we trained the system on detecting the disease by using heat maps and other machine learning tools, and we found a sensitivity and a specificity of approximately 92%. Of a binary, which means the algorithm was able to either say there was disease or there was no disease. Subsequently, we had support from Government of India's Department of Biotechnology, and this is a workflow that's still going on, and we are going to completely conclude this work by the end of this year. So we're just about 4 or 5 weeks from completing it, and it's ready, and it's now being validated in multiple centers, and it should be soon integrated to a camera that I'll subsequently talk about in this presentation. So what we were doing here was we said, okay, so now we have a decent, robust model to detect the disease, but can we go beyond? Because there are AI systems across the world that look at the plus disease or severity of the vascular tortuosity. And they work really well in being able to detect a treatment requiring image. So we said, along with that vascular severity or plus disease, can we combine the combined intelligence of a binary detection software algorithm and also a plus disease? So our image, when the images got inputted into this new workflow, it was able to filter out either a macular center or a disc center images, which focused on our plus disease detection, and a temporal image, which focused on the ridge detection. So how the algorithm was built was, if there was plus disease, then automatically it was flagged as an urgent referral, meaning, of course, that this baby possibly needs treatment. If there was no plus disease, but then there was some disease in the temporal image, the ridge was there, or the temporal image picked up the yes, no as yes, then yes, this baby had to be referred, but perhaps not urgent. So there was a not urgent referral vis-a-vis an urgent referral. And then if there was no disease, on the temporal image, and there was no plus disease on the disc center image, but there was, let's say, immaturity or anything else, then this was flagged off as follow-up. So what, and this is a typical report of what would happen. As you can see on the left, you would see the heat map all around the disc, which is where the plus disease or the tortuosity is, and that would be an urgent referral. In the middle, you would see the ridge, again picked up on heat map, and then reported as disease or ridge, and then flagged off as a referral recommended. And then, as you can see on the rightmost, immature retina of any form, wherever the vessels ended, and it would be reported as no ROP, but follow-up. And this is how we went on to validate it. The real world validation was offline, because we believed if an AI system has to work in middle income countries or anywhere for that matter, it has to work without the requirement of the internet, because that's the way the rural logistics are. So what we did was we had level 3 technicians and we had ROP experts. Level 3, as I explained, were the ones who are highest skilled, who had years, in fact, in some cases, more than a decade of experience. And then this was then divided as type 1 ROP requiring treatment, type 2 ROP requiring follow-up, mild ROP, as you can understand, a little below that, and no ROP, which was immature retina. And then the Medios AI would then detect it as urgent referral, non-urgent referral, and follow-up based on the filtering mechanism. And these were the results. This is now in submission, and we hope that it will get published soon. This was a relatively small cohort of just under 250 babies. This was for us to understand what this validation of both are. And if you look at the ROP specialist's ground truth, where the ROP specialist decided whether there was plus, there was disease, whether it needed treatment, follow-up, or what kind of ROP, the algorithm did not miss a single case of type 1 ROP, type 2 ROP, or even mild ROP. What I'm basically trying to say is this algorithm missed no case of ROP when you compared it with the gold standard. What's interesting also, as you can see from these curves, that this AI model worked equally well on the RetCam 3, on the RetCam shuttle, and the Forest Neo camera. So we were hoping that this would happen, that it would be device agnostic, and fortunately the results were encouraging. We then gave out this algorithm for the retrospective use for all our level 3, level 2, level 1 technicians in different zones of the KIDROP program. And we said, play around with it and give us the feedback on how the user interface is, how does it really work offline, in low internet settings. Do you like the image processing or not? Does it help you if you got the AI report as this requiring urgent referral? Were you more biased to actually getting inclined to saying the same, and so on and so forth? And interestingly, we got a lot of feedback where we were able to improve the algorithm. I put that stage 4 and stage 5 because one of the feedback we got from our imagers was that in the rare case of a referred case of stage 4 or stage 5, the algorithm would say ungradable. And that's because it was not trained on those images. So in some way, that was good validation for us because we had trained it only on stage 1, 2, and 3. Because as you can understand, that's where we want this to work, to be able to detect early stage and prevent any baby from even going to the advanced retinal detachment. This is then the next set of work that we have done, and this is going to be presented next week at the World ROP Congress. This is a slightly larger cohort, and this was level 1 technicians. So these are very early career, limited experience, almost rookies who've just sort of learned how to image and are going back into their centers to be able to start screening. And now they have these tools with them, and that's the standalone AI sensitivity. Now, what are these being compared to? Again, the gold standard of 2 ROP specialists completely blinded to the diagnosis, adjudicated by a 3rd ROP specialist. So that's around 96.5, close to 97%, a standalone AI without the technician making his or her report is concurring with the gold standard. And if you look at the 83% or close to 84%, this is a technician, a rookie technician without the support of AI. So perhaps then this begs the question, can a standalone AI help in regions with less experienced technicians who are just learning in, or perhaps no ROP specialists to even give them the gold standard? And of course, all of this was offline. Let's quickly stop at an AI poll question. I believe this is my last poll question before I wind up. So with respect to AI and ROP, you believe that in your setting, of course, AI has a limited role in ROP screening. AI combined with ROP cameras are the future. AI will have no practical role in ROP screening. So limited, no role, or you want to see this combined with a camera. And a massive majority of y'all feel that AI should be combined with a camera. And a really small proportion say that AI has no role. So I'm glad y'all think that way. So let's talk about the expansion and how we've been trying to integrate AI with a camera. So now KIDROP has moved outside of Karnataka state. We are now in 10 states, and here I must acknowledge the support of an NGO called Have a Heart Foundation, who have helped in the capital expenses and in many cases the operational expenses as well of all these states that you see. In a short period of time, because this started somewhere during the COVID pandemic. So between 2021, late 2021, 22, in about just 3 odd years, 15,000 plus unique infants have been screened and over 1,000 detected for treatment. And that's really the change you can make when you expand this exponentially. And most of these places have just a single camera. Now, this is a demo, not on a real baby, of the dashboard that we are creating with Forest Health, which is ready now, which is being integrated for the use of a nationwide or perhaps an international usage, where the operator would come up with his or her diagnosis and submit the decision of whether it needs the same thing that you saw right in the beginning, needs treatment, needs follow-up, completely normal. And that report then goes to the expert and he sees on his dashboard what requires his or her urgent attention. So if there are 10 babies from this region where the technician has flagged as may need treatment, the expert has to first look at that, what you're just seeing in front of your screen. The red shows 5 babies, so he or she will go there, concur or disagree. And the moment that happens, this populates on the dashboard both of the expert and the admin and the super admin who's looking after all these programs. And then this goes back to the operator in the rural area for them to understand that this is what the decision was from the expert. And now this is the new camera for those of you who have seen it in India and hopefully will see it at the World ROP Congress next week. This is Remedio's new camera. They call it the Nubo 130. It was just launched this month. It is portable and more technical specifications of these are perhaps available online. We are now in the final process of validating it along with the combined AI algorithm. So it works pretty much like the Neo, the added advantage perhaps being that it will have AI to begin with. They also say that this will be able to work on a smaller pupil. And that's because traditional illumination has been around the crystalline lens, but their clear perivision, for which they have some patents, the illumination is right in the center. It goes through the crystalline lens. Our initial clinical validation has shown that this might be an impediment for cases with aphakia, surgical aphakia, but nevertheless, it's able to illuminate better even through a small pupil. These are some of our initial clinical validation. We'll have the publication out soon. I'm zooming this picture on your left to show you that we're able to trace these vessels after laser, even into the laser marks, growing into them. I hope you can see the 2 blue arrows, which are, this is captured on the Nubo, and we believe that the peripheral illumination and the peripheral resolution is very good. With the help of Aisha, an organization in the UK, we have collaborated along with Have a Heart to have some work going on in other countries. Indonesia for the past 4+ years, and there are some nations in Africa as well. Some of it is being funded. Some of these centers have been funded with a camera. Others we are collaborating for training, and some others we are hoping to help them set up a telemedicine project, and in others, the artificial intelligence as well. In terms of what impact you can make, this is how you use a WHO formula. The number of babies you've prevented from blindness into the per capita income. You need to work this out for your region, your country, into the life expectancy. I'm using the current estimates for India. That's about close to $1 billion of blindness burden saved across these 18 years in the KIDROP program. But look at the potential that remains to be achieved. If we expand to the 10 states that we spoke of, we can save close to $200 million of blindness every year, whereas 900 million over 18 years. So that's the quantum of difference you can make if you're able to expand this program. But nothing happens alone. As it's classically said, it takes a whole village to run a marathon alone. And I'd like to acknowledge our founder of Narayana Nethralaya Eye Institutions, the late Dr. Bhujang Shetty, my colleagues, Dr. Snehal Bavaskar, Dr. Sushma Jayanna, and all these tireless heroes of our KIDROP family who are screening in the outreach relentlessly, day and night, pandemic or no pandemic. And below, of course, as you see, some of our babies and all the patients who've put in their trust in our program for all these years, some of them who've grown now to become adults. I'd like to end by thanking all our collaborators, beginning with Government of India. Thank you so much, CyberSight, and all of you for having joined in on this webinar. I was given a set of questions before the webinar. A lot of you had already sent it in. So I'm going to try to group these and answer them together. When ROP was diagnosed as, okay, so the question here is, how early do you need to diagnose ROP to have good vision later? Well, obviously, we want to be able to, and I presume you mean treatment requiring disease, because if they have type 2 ROP that spontaneously regressed without sequelae, then they should have normal vision if you've taken care of the other ocular sequelae. So if you treat them successfully with laser, anti-VEGF, or both, they have more than a 95% of having 612 or better. In our own setup, they reach 6, 7.5 or 6 by the age of between 3 and 5. We have a very strong follow-up schedule, and that's moving into the next question of the follow-up. So our follow-up is, we start as early as the third corrected month. We do a 3, 6, 9, 12, 18, 24, and 36. So 36 is 3 years, and after that we do an annual checkup. In India, according to the RBSK guidelines, we need to do a follow-up at least till 7 years of age, and so we do that mandated, but most often our babies are coming to us even after. The next question is on the same thing as the sequelae, so I'll skip on that. Why are premature infants higher at risk? Well, that of course is because of the pathology of the vessels. When you're born preterm, the vessels have abruptly stopped in their growth, and these vessels have to grow normally. And because of the environment they are in, there are several risk factors. Of course, the most important one we always believed now for 5 decades was hyperoxygenation, but truly that's not the only villain. We have, at least in India, we have published a group, all of us have published over 34 unique risk factors. And so a sicker baby has lesser chances of the blood vessels growing forward, and then these are admitted, and then they develop the disease because of their abnormal angiogenesis. Why is early detection of ROP so important for long-term vision? Well, I think we've just got past that. What are the current ROP screening guidelines? So that again, this question is coming outside India. So I presume that you're from a region that does not have an ROP screening guideline. So what you must try to do is to, at least before the government brings before your local government gives you your guidelines, you must galvanize your professional body. I'm sure you all have an ophthalmology society, perhaps a retina society, perhaps a pediatrics association. I think bringing them together and coming up with society guidelines is the first step. which can eventually then become, then you can advocate it to the government to make it a national guidelines. What challenges do clinicians face when implementing ROP screening programs? Well, you begin with complete lack of awareness in centers that don't have ROP screening programs. When we began, since we were the first program to use cameras or imaging techniques to do ROP screening, that was the first pushback. They all believed that we should not be doing it that way and that you needed the ROP specialist to come in and do the screening, which was not feasible given the limited number of specialists we had. The next question, I see one question is getting repeated. How can artificial intelligence support ROP screening programs? Okay. I hope that some of the slides that I showed answered a part of that question. But I think to talk a bit more generically, I think if we have AI assisting a non-physician taking an image, because that's probably the best way to make this scalable, where you don't have the ophthalmologist himself or the pediatrician himself do this imaging, because again, they are busy physicians who have to take care of their clinical and surgical duties. So if you can train imagers, there is a wonderful paper by Alistair Fielder's group talking about the paradigm shift in ROP screening, where they speak of neonatal nurses becoming the key stakeholders of using imaging, wide field imaging, and then the ROP specialist only looking at these images in a telemedicine format. Well, that paper came out before AI was a thing. Now imagine now these same imagers being assisted with the AI algorithm. So as you saw from our publication and the one that we've put in submission, when the AI is supporting the diagnosis, rookie technicians have more confidence in making that diagnosis. As I showed you, algorithms such as ours are now 100% sensitive and able to predict, able to pick up any ROP that needs treatment, and in fact, any ROP for that matter. This is a question from. My question is how to screen for ROP prophylaxis later after the initial diagnosis and treatment. Again, I think you are referring to the follow-up. Well, again, that would depend if you have guidelines. And in India, we have guidelines to do it till the age of 7. How frequently you do it depends on your institute protocol. We do it at 3, 6, 9, 12, 18, 24, and 36. What is the cost-effective medical? One second. A cost-effective AI-based screening to be measured in policymakers and hospital administrators to encourage widespread adoption. Well, I think AI is here to stay. It's certainly not going to put people out of jobs if that's the fear we had. It's only going to help us do our job better. As you can see, that will drive technology to lower costs and make it more scalable. Can other cameras like RetCam use the Forus platform for documentation and review? Absolutely, yes. If you're referring to the dashboard that I showed that was developed by Forus, yes, a dashboard is simply a UI interface which plugs in to your own ecosystem. In our case, all the cameras in our ecosystem, we are now screening in about 190 hospitals in our state and 110 hospitals outside the state. So close to 300 NICUs in the KIDROP and the KIDROP outside of our state across India. All of them can be plugged onto a single dashboard. And in your country, all you would need to do is bring all that together into your ecosystem. A question coming from, we try to build an AI system for a small set of data and show promising performances in detecting. Yeah, absolutely. I think what you're trying to say is that the learning has to happen on a very large data set, and promising the moon by just showing validation data of 200, 300 odd images is not the way to go. And I completely agree. And this is why we needed to develop our system. If you remember my first slide, which we've published in Frontiers of Pediatrics, that was over 200,000 images. And now we're validating it in multiple centers with, as I showed you, about 3,500 imaging sessions every month. So that is going to be a very large cohort. While we learned on close to 200,000 images, we are now going to test it in tens and thousands more. And we would encourage any of y'all who want to collaborate with us to reach out to us, because we'd be very happy for you to use this in your setting and to tell us how it would differ perhaps in your ethnic backgrounds or the camera that you use and so on and so forth. But I completely agree with you. Can we see far periphery by the Neo cameras? Yes, indeed, we can. The Forest Neo has 130 degree. In fact, their HD camera boasts of 150 degree. The HD camera also has the angiography mode, so that's what they claim. And the Nubo claims also of 130 degree. I think you must have seen it on the video in the demo. We were able to image far out to the Ora Serrata, and that's actually functionally 110 plus, but just by the study of that optics, 130 plus. Is reducing the PO. So what the question here is, of course, more, perhaps this is a neonatologist asking the question in terms of the oxygen blending and in your incubator. Absolutely, yes. While I said that oxygen is not the only villain for ROP, it is a very important risk factor. And neonatologists will tell you oxygen should be treated like a drug. And like every drug, it has to have a dose, it has to have a frequency, and it has to have a rationale for use. Unfortunately, many NICUs do not have blenders. And I think I speak not just for my country, but several other lower middle income countries. And I think that is where we need to work with our neonatal groups, and perhaps even reducing the cost of blenders and maybe using room air blenders without compressor. So I agree with you, that can certainly modify the severity of disease. A question from a Jamaican neonatologist that you run a level 2 or 3 NICU with no access to ROP screening. Ophthalmologists are all off-site. This would be definitely a great program. I agree with you, and I think telemedicine is here to serve the cause of not just LMIC settings, but also, for example, the Australian report that you saw. When they came to us, they said they had a unique problem. Many of their ROP specialists, now Australia is a high income, very well developed economy. But why were they looking at telemedicine? Because they found that their ROP specialists were mostly on the two coastlines on either side of that continent. And every time there was a baby in the central area of the country, they had to be airlifted for ROP screening to one of the two destinations. And that was being done at federal expense. Again, not cost effective. So they said perhaps telemedicine would be the answer. And I agree with you. And where you have fewer ROP specialists, this would be the way to do it. Using a low-cost camera, training your nurses, maybe training you as a neonatologist to take these images, AI assist that, and get it onto the ecosystem where a remote ophthalmologist, now that remote ophthalmologist need not even be in Jamaica, can be anywhere else in the world who is giving you that diagnosis, and all of that happening within minutes, if not within hours. Do you use laser photocoagulation under general anesthesia? No, fortunately, in India, most of us are trained very well to do laser under topical anesthesia. And that's a question maybe for another webinar on anti-VEGF. When do you treat after giving injection and so on, because that would be a topic on its own. Since today we are focusing more on program, telemedicine, and AI, we won't really talk about the follow-up and hybrid treatment, but I would like to, many of you all had asked this question even before the webinar, the questions I got sent. So there has to be a definitive follow-up period after you give an injection, anti-VEGF that is. Very few proportion of babies, especially with zone 1 disease, will completely vascularize. You have to have a very definitive protocol to follow them up to detect either a persistent avascular retina as defined by ICROP3 or a recurrence, and you need to go back and do that treatment. Whether you give a second injection or whether you do a laser, again, that's a separate topic, but that is, and if you're looking to see what we follow in India, you'll soon be seeing a publication of a group of the Indian ROP Society's guidelines, and I promise you we'll share that when it is out. But we are definitely advocating for a hybrid treatment, that is, inject follow-up, and eventually majority of these babies will require laser. So don't go with the thought process that you treat that once with injection and everything is good to go. No, that very seldom happens. The next question is again of oxygen, so I'll skip that. What is the, okay, again, this is laser versus anti-VEGF, and I only briefly touched upon it because that's not the focus of this webinar. After the ROP, when should we start vision stimulation? That's a great question. On follow-up, well, since we start screening in our program for vision at 3rd month, we have our own algorithm. We know that by the 3rd corrected month, their vision should be on a teller acuity card level converted to Snellen's. They should be between 20 by 540 to 20 by 670. So if they are worse than 20 by 1000, 20 by 1400, that's when we start vision stimulation in our program. Again, that would depend on how early you are testing for vision and what your normative data looks like. Someone's asked for a certificate. Well, if you mean the CyberSight certificate, I think that's there on their website. If you're talking about getting trained by us and certification, well, there is detail on that on the KIDROP.org website. You can reach out to us. We are constantly training ophthalmologists, train technicians, imagers round the clock. So you're most welcome to apply, and we'd be very happy to train anyone. How can I join the IROP Society? Again, please look for details on the website. Currently, of course, it's open only to Indians and only to ophthalmologists. We might soon open it to associate membership to non-ophthalmologists as well. So I could not make out from which country that's coming, so I'm just answering in the generic. Is there a chance to unify all AI systems for developing countries? Hence, they have almost the same. I hope so. That would be a utopian way of looking at it. I certainly hope that all of us work together and not see each AI algorithm as competition to each other, because at the end of the day, I think our aim for all of us is to prevent blindness, and whichever system, whichever AI algorithm works best in your ecosystem, maybe your ethnicity, is something that you should be able to log in and make it part of your ecosystem. So I certainly hope that AI systems will be able to unify the world. And that's really what ChatGPT is doing, isn't it? So why are we falling behind in ROP? Any oral medications that can prevent ROP in preterm? Short answer is no. Of course, there are studies more recently on beta blockers and so on. Again, out of the scope of this webinar, so I won't go into detail, but short answer would be no. You can prevent and reduce prematurity, but no drug, no magic bullet to reduce it orally. Right, I think we have just about a minute or two, so I'm quickly trying to see if I can group up the questions and answer it together. What is the role of an optometrist can play in diagnosis and managing ROP? Well, certainly, as I showed you in our own program, we have plenty of optometrists who've been trained to become imagers, but also you through your optometry societies can promote awareness on which babies require to be screened and treated and help in the movement. Right, in the Indian ROP Society, we have an ambassador program which actually looks at promoting ROP screening practices through optometrists. So that's something that you can be part of. Is the Nubo camera available outside India? The short answer right now is no, because they will be looking for their perhaps their regulatory FDAs. But if you are going to be present at the World ROP Congress, you'll probably see it. But very soon it will be available. The Neo Forest camera has an FDA, and that's currently available across the world. You are free to reach out to both these companies independently. We have no financial interest in both of these companies. Okay, I think we are at the end of the hour, so we'll stop right there. Thank you so much once again for being here, for being such an engaging audience, and for listening in. And this has always been a wonderful opportunity to present at CyberSight. This is World Prematurity Fortnight. Last week, we had Dr. Pradhan from Nepal speak on World Prematurity Day. It's my honor and privilege to speak today. Thank you so much, Team CyberSight. Thank you very much for being a wonderful audience. Thank you.